Welcome, everyone. I am super excited to be here with each and every one of you, along with an amazing person that I have the pleasure of knowing. And we are in each other's lives for real, not just not just a Facebook or a social media thing. Thank you for joining Advocating for My Uterus for Menopause Awareness Month. And today we have with us Crystal Harris, and I'm excited that she is here. Crystal and I met, just a little background, we met a long time ago. And not that long, because we like 21, but not that long ago. But we met quite some time ago. We were in a leadership program in Genesee County in Michigan, Leadership Genesee, or was it Genesee Leadership Genesee or Genesee? Okay, Leadership Genesee, and it was absolutely amazing. And so we met, we connected. It was a phenomenal leadership program, and we stayed connected. And this is someone that I look to for prayer. We have prayed for each other. We have talking about different things. And she is all around amazing. So I am glad that I'm able to share her with you all. Please, if you are on Facebook, feel free to go to my Facebook page, Joyvina Evans, and share this. If you want, feel free to share it. We would like to get this information out to as many people as possible. So while we may feel like, myself, I'm not actively in any way, shape, or form, like going through menopause or perimenopause or anything like that. But I know if it's God's will that I continue, on this journey, I will have to deal with this as well. So we want to make sure that we're able to share this information with as many people as possible. So we're going to talk about perimenopause as well as menopause, and Crystal has an amazing presentation for you all. We are going to ask if you can hold the questions until, feel free to type in a chat if you want, but we are going to wait until the end for questions. So I am going to turn it over to Crystal to share information with you all about herself, and then we'll share the presentation and get going.
Good afternoon, ladies. I don't see any gentlemen in the room, so I'll address the ladies. Thank you so much, Dr. Joyvina Evans. Put some respect on her name. It's such an honor and a joy to know you, and thank you for the Advocating for My Uterus organization for having me today. You only get one uterus, and I am a huge patient advocacy fan. I do not believe that a provider knows more about a person's body than the person knows about their body. And so I strongly encourage us to become our own advocates in terms of our health. So many times we can avoid issues and complications by just saying, I don't know if that's right. And a good provider will at least hear you out and explore what you're saying. So let's jump right into the content. I am a nurse practitioner. I've been a nurse about 10 years and a nurse practitioner for 5 or 6. And I recently launched a faith-based mental health practice where we seamlessly integrate faith and medicine to help you meet your mental fitness needs. I'll get to that later. The angle that I'm coming from today is menopause and mental health and how those things intertwine. I will talk about perimenopause. You can go ahead and share the presentation. Here I will talk about perimenopause as well as menopausal symptoms, and then we'll get to treatment and the relationship between menopause and mental health as well. Let's jump right in, shall we? I've got a little video to share with you, so I'll have Joy play that, and I'll be back with you after this commercial break.
Try Dove Dry Spray. Leaves underarms feeling instantly dry and soft, and you more confident and carefree.
All right, so that was just an intro. Now I'm done, right? That covered everything. So we'll go into a deep dive for all these
Already out of
things.
breath and I haven't
Cover some
even said
objectives.
a word.
Ian, could you mute yourself for me? Hearing something.
Hey everyone, welcome or welcome back to my channel. My name is Catherine. If you're new, I would love for you to subscribe, join the family. And if you are returning, thank you so much for watching.
Okay. All righty, so we're just gonna go through some objectives. That will be slide number 3. My lovely assistant, she knows she's gonna do this for me today. We're going to establish the groundwork for understanding perimenopause, menopause, and postmenopause. We're going to discuss signs and symptoms and outline some treatment recommendations. You can go to the next slide, Joy. Let's talk about menopause and where it comes from. Why does it start? How do our bodies make this natural transition? It starts with perimenopause. This is premenopause. Perimenopause literally is translated as around menopause. This is the syndrome, the series of symptoms that begin to happen as we go and we make the natural, I highlighted the word natural transition from our reproductive to our non-reproductive years. This is one of the it's not a disease process, but this is one of the health syndromes that cannot be reversed. This is something that every woman will have to face in some way, shape, or form. And so it's not something that we are to try to fight against. It's more so something that we're going to try to work through and try to ease symptoms. These changes can begin as early as our mid-30s, but most people happen in their 40s. And then, of course, as the video indicated, the average age of menopausal onset is 51 in the United States. You can go to the next slide. All right, some of the causes. This naturally occurring transition is a result of declining reproductive hormones, namely our estrogen. As we approach our late 30s, our ovaries start to make less estrogen and progesterone, and I'll go into detail about those later. These are the hormones that regulate our menstrual cycle. Our fertility levels decline. In our 40s, our periods become longer, shorter, heavier. That's when we start to notice changes in our menses. And this continues until that average age of 51. Another cause of menopause is surgery. So if you have your ovaries removed, that obviously changes your hormone levels, your estrogen levels. Your periods will stop and you'll likely start to have almost immediate onset of menopausal symptoms. This is probably one of the less known causes of menopause is chemotherapy and radiation. If you have treatments related to any type of cancer, blood disorder, in regards to chemo and radiation therapy, these cancers can induce menopausal symptoms during the treatment itself or even after the treatment shortly thereafter. And then lastly, if you have a primary, we call it primary ovarian insufficiency, about 1% of women experience this before the age of 40. You'll see me, I hope you see me looking down. I'm trying to read my notes. Premature menopause may result from the failure of your ovaries to produce normal levels of reproductive hormones, and that is called primary ovarian insufficiency. This stems from genetic factors or autoimmune disorders, but often there's not really a cause related to primary ovarian insufficiency. For these women, hormone therapy is often recommended, and sometimes before the natural age of menopausal onset. So these people will have treatment for menopause even well before the years that they're supposed to experience menopause. You can go to the next slide. Let's jump into some of the symptoms. So there are many different symptoms as we saw in the video. And these symptoms, as we discussed, are caused by the fluctuation in our estrogen levels. The level of estrogen, which is the female hormone in your body, it rises and falls unevenly during perimenopause. So there's supposed to be a natural ebb and flow of these levels, but when you go into menopause, these levels start to kind of go haywire. And that's what causes the irregular periods, the vaginal dryness, night sweats, sleep problems, mood changes, which we'll get into later, weight gain, hair and skin changes, and even loss of breast fullness. Skipping periods during menopause is common. It's important to note that during perimenopause, it's not abnormal for you to have irregular periods. And it's important to note that you can still become pregnant during that time, even when your period is irregular, because you still go through the ovulation cycle. Once you have a 12-year period where you have not had a menstrual cycle, then you are officially in menopause. That, in conjunction with the other symptoms, is the official diagnosis. We'll get into specifics about diagnostics later on. Your periods can get longer, they can get shorter, they can get closer together. These are all of the menstrual changes that are common when you're going through menopause. We'll go to the next slide, please. All right, so when we get into diagnostics of menopause, this is one of those processes and one of those health syndromes that doesn't usually show up on a CAT scan, an MRI. These are, you'll go to their doctor and say, I'm having hot flashes, or I'm having vaginal dryness. These are symptom diagnosed syndrome. So usually that's enough. When you present to your medical provider with a symptom, occasionally they will request a FSH level. That tends to increase with menopause. And then it's important to know that you may also be able to purchase an over-the-counter FSH test, and that will tell you at home. Now, the issue is that our FSH levels can fluctuate. And so if you happen to purchase a test and you do it at home, it may not be clear whether or not you're in menopause, but all you'll know is that your FSH levels are changing. And it's still important at that time to go and seek professional help. Another test that they can draw, just a simple blood draw, is your thyroid stimulating hormone. And those levels will increase when you're going into menopause. The best thing is just to seek professional help with your medical provider, tell them the symptoms that you're experiencing, and then have them diagnose you from there. Go to the next slide. So we talked about the symptoms that are normal. These are the things that are not normal. These things should drive you to your doctor's office. If you are bleeding after you're having menopause, that means you've had 12 months where you have not had a regular menstrual cycle. A regular menstrual cycle. Irregular menstrual cycle is totally normal as we make the transition from perimenopause to menopause. But once you have experienced a 12-month period where you have not had a menstrual cycle, and then you begin to bleed afterwards, that's a reason to go and see your doctor. Spotting or bleeding between periods. So let's make a clear distinction, because you may say, well, you said my periods could be longer or shorter. You should be having a full menstrual cycle, even if it's longer or if it's shorter. But if you complete a menstrual cycle and then you spot or bleed in between that, that's a reason to go see a doctor. I hope that's clear. If you have heavier periods with blood clots, heavier periods are normal. Heavier periods with blood clots, that's something that you should go see your medical professional about. Excessively longer periods. So if your menstrual cycle is normally 4 days and you're continuously having 7-10 day cycles, you should go see your healthcare professional. If your periods are closer together in an abnormal pattern, you should go see your healthcare professional. Go to the next slide. This is the emphasis on estrogens. Estrogens are a group of reproductive and sex hormones, mostly made by the ovaries, which is why if you have your ovaries removed, you automatically have lower estrogen levels, and that sends you into menopause. They're also made in small quantities by the adrenal glands and by your fat cells. They're responsible in our bodies for regulating our menstrual cycle, and they have effect on many other bodily functions like we just saw in the video. That's why we have hair and skin changes. That's why we experience weight gain and all these other manifestations of the menopausal syndrome. Next slide. All right, three main types of estrogen. Actually, there are four, but these are the three main highlighted types. Estradiol is the first one. This is the most potent form, primarily responsible for, primarily active during our reproductive years. Estriol is primary form during pregnancy. Those levels increase during pregnancy. And then estrone is the last one that our bodies make after menopause. Next slide. These are some key differences. I want to make sure to highlight this, that we have some key differences between menopause, between perimenopause and menopause. And you'll see the little table here. On the perimenopause side, we have irregular periods, totally normal, longer, shorter, though those fluctuations are normal. It is also important to know that you're able to get pregnant during this time. If you have a cycle, you can get pregnant. The difference is when you're in menopause, you're not having periods at all. You're not having bleeding at all. And then you're unable to get pregnant. Next slide. Let's go to some treatment options. So as we mentioned earlier, this is a natural transition. This is not something that we are looking to reverse. Like Dr. Joy shared, I'm a Christian. You can't bind this and loose it. You can't cast it away. This is going to happen to all of us. We all have to go this route. Our manifestation of symptoms will be very different, how we each present during our menopausal phase, but we're all going to have to go through this. And so because this is a natural transition, the emphasis for treatment is focusing on the relief of symptoms. And so we're going to talk about hormone replacement therapy. We're going to talk about lifestyle changes. We're going to talk about mental health support. So the focus is on relief of symptoms. There is an option for hormone therapy that's oral estrogen in the form of birth control, as most lay people would know it. Vaginal estrogen, which can help with dryness, a low dose antidepressant, gabapentin, clonidine, and vitamin D for bone health. I'll go through each one of those and how they're helpful. Estrogen therapy is most effective treatment option for relieving menopausal hot flashes. Depending on your personal and family medical history, your doctor may recommend estrogen in the lowest dose and shortest time frame needed and necessary to provide symptom relief. If you still have your uterus, you'll need progesterone in addition to estrogen. Estrogen also helps prevent bone loss. And then we'll talk about vitamin D replacements as well. Long-term use of hormone therapy may have some cardiovascular as well as breast cancer risks. So you have to kind of balance the risk versus reward. Have those in-depth conversations with your healthcare provider about, okay, how severe are my symptoms? How aggressive do we need to be with treatment? Is this manageable with lifestyle changes? Is medication required for me to get through this? Some ladies can get through their menopausal phase and not have any medication. Other ladies, their symptoms are so severe that you have to have some sort of support. All right, so you want to have that conversation with your doctor about a vaginal ring, water-based lubricants. What can I do to deal with vaginal dryness if that's up there on your list of priorities, if that's something that is discomfort, causing you a lot of discomfort with intercourse or even painful urination. You can have that conversation. Low-dose antidepressants can be helpful and help to not just regulate moods, but also help to decrease menopausal hot flashes. Little known fact about that, but a low-dose SSRI, which is a selective serotonin reuptake inhibitor, that specific drug class can have a 2-4. So you can experience improvement in your mood swings and fluctuations, which tends to be common with the menopausal syndrome, as well as a decrease in menopausal hot flashes, which are pretty life-changing for a lot of people. Gabapentin as well, it's approved to treat seizures. I've given it for anxiety. It can help with neuropathic pain, but it's also useful in women who can't use estrogen therapy for whatever reason. And it can also help with hot flashes, specifically at night. Osteoporosis is something you have to guard against because estrogen, when you have a decrease in your estrogen levels, it can put you at risk for osteoporosis and a decrease in your bone health. So a vitamin D supplement can help to strengthen your bones. The next slide, please. Let's talk about the things, the low hanging fruit, the things that we can do to help to support, like we talked about. We're not trying to reverse symptoms necessarily. We're trying to support through this natural transition. What does that look like? Just regular stuff. Okay, let's dress in layers. Let's make sure that should a hot flash come and we're at dinner and we're out with our friends or we're in the middle of a business meeting, that we're not stripping down to the bare bones. We have appropriate levels in our dress, layers, and we can remove comfortably. That may mean for you that you keep one of those cool towels that you can wet really quick and you can appear to be, blend in, and you're not making yourself so uncomfortable that you can't tolerate volatility in your environment. Let's avoid the triggers. For some people, it is caffeine. For other people, it's smoking. We'll get to that later on the list. Other lifestyle things that we could do is water-based lubricant, as we discussed. Healthy sleep habits is so important. That what do I mean by that? I mean, I call it sleep hygiene. That means you try to regulate your sleep cycle. You try to set your circadian rhythm. Okay, I go to bed at this time. I wake up at this time. And that is very helpful as well. Kegel exercises. I don't know if people still do that, but it's very important to keep your pelvic wall strong. So you can do Kegel exercises. They even sell like weights that you can put internally to increase your pelvic floor strength. A balanced diet, a balanced diet with lots of vegetables, just the basic stuff, fruits, vegetables, whole grains. You want to limit your saturated fats and especially processed sugar intake. Those things have a tendency to aggravate menopausal symptoms. Smoking can increase your risk of heart disease, as we all know, but it can also spur on menopausal symptoms like hot flashes. Who knew that? And then lastly, exercise. Exercise, we cannot promote that enough, because not only does it help with emotional regulation, but you feel better. It helps with circulation. It helps with your sleep. It helps with your sexual arousal, because sometimes with women, as we have these fluctuations and decreases in our estrogen levels, our sexual libido can decrease as well. So we want to make sure and curb as many of those symptoms as possible. Next slide. This is life after menopause. So, okay, let's presume that you've gone through your menopausal phase. You've had premenopause, you've gone through menopause, you're beyond 12 months out from your last menstrual cycle. What does life look like for you in terms of your health picture? Let's discuss some of those things. We need to be aware that the risk of some of these things, like cardiovascular disease, like osteoporosis, like urinary incontinence and sexual dysfunction, and finally weight gain, these are the things that we have to kind of guard against. And so how do we do that with cardiovascular disease? We want to eat well and live well. We want to move our bodies. We want to eat balanced. We want to avoid smoking. For osteoporosis, we want to make sure we're taking a vitamin D supplement. If you're in Michigan or one of those states where you get all 4 seasons, we kind of go into a dark season between the fall and the winter months, where we're not getting sun in the morning because we're going to work, and we're not getting sun in the evening because we're coming home from work. A vitamin D supplement will be excellent to add to your repertoire for your overall health picture. Urinary incontinence, that's where we get back to these Kegel exercises to build up our pelvic wall floor so that we are warding off as many of these symptoms as possible. Sexual dysfunction, as we discussed, exercise ties into that. When you exercise, the happy hormones go up, your libido goes up, you're treating your body well, you're more confident, you're mentally sound. All these things play into your sexual dysfunction. And then lastly, weight gain. So we want to try to ward against that. That midlife spread is how my mom put it. The midlife spread. We can avoid some of these, right? Next slide, please. This is my bread and butter when we get to menopause and mental health. this naturally occurring transition, which we all know is coming, can be very difficult because here we are trucking along, we're, in our adulthood, and we have lived life in this body that has not, for a lot of us, changed or fluctuated very much. And then all of a sudden we go through this transition, through this season of life where our skin starts to change. Listen, ladies, it's like an arsenal. We know our skincare products, we know our body products, we know what our hair likes, we know what our nails like, and then things go haywire. And we have to try to figure out, okay, what is my skin like now? What do I need more hydration? Do I need more facials? My hair, skin, my nails, my emotions on top of that are starting to seem out of whack. Now my moods are swinging. I'm happy in the morning and frustrated or angry in the afternoon, sometimes in the same conversation. I've heard of women having crying spells during their menopausal syndrome. It's like an upheaval of sorts. It's like an upheaval of sorts. And so we want to really explore, okay, what does this look like? When should I go seek medical help? Let's just break down, first of all, the linkage between menopause and mental health. As we discussed, this upheaval can cause an adjustment disorder. It can cause, okay, I'm changing so much and I'm having a hard time making this transition between who I was and who I'm becoming, between my body changes. You can have some body dysmorphic disorders, meaning, okay, I'm changing so much externally that I'm not comfortable with how I look anymore. You can have grief, significant grief over my former life, specifically my ladies and sisters on here who have never had children. That period of time, even if I've had patients, if you never even wanted children, just the thought and now the reality that you can no longer have children can bring an onset of grief. Okay, I never wanted kids, but now I can't. That can really cause some emotional and mental turmoil. And so those things have to be worked through. Depression is another one. Too many life changes all at once. Adjustment disorder, depression about, okay, what does the onset of my life look like as I look out ahead? Who am I now? Maybe I've built my identity around how I look. A lot of people have issues with that. And then anxiety, that feeling of the loss of control. Because it's a natural transition and we're all going to go through it, this is something that happens to us. We do not get to control. All my type A's should have put their hand up right there. That would be me. I like to have some sense of control. And when that is lost, that can cause some angst and some worry. Some worry. Everybody who's a high achiever, I see all these doctors and MDs and everyone in here. I know that you all have some sense of, man, I want to know what's going to happen to me and how can I adjust appropriately. This presentation today is to arm you. This is information that you can take into your regular daily life to say, okay, I can't control what's coming, but I can have a hand in being prepared as possible to take life as it comes and to coast through something that could potentially overwhelm me if I did not have the information. So this information is to arm you for your arsenal. Grief, adjustment disorder, depression, anxiety. Those are the four main things. And I would add to that body dysmorphic disorder. Because if you've been a brick house all your life, and then all of a sudden you got a middle-aged spread, that can mess with you, honey. All your clothes don't fit. Ain't nobody got time for that. That's something that we really need to consider as a possibility that could happen. And how are we going to adjust? How can we address underlying belief systems around our appearance, around the life that we have built? We have to have those conversations. Y'all can tell this is my passion. I love to talk about mental health. All right, so I don't even know what the next slide is. Let me go to the next slide. Oh, this is the practice that we launched just a couple of weeks ago. My business partner and I, she is a licensed therapist. She has been for about a decade. And this is our practice, Sound Mind Health Services. We offer caring, compassionate, and consistent care to meet your mental fitness needs. These are the services that we provide. mental health examinations, medication management. I am a nurse practitioner. I do prescribe. And then we also offer counseling and therapy services. Our particular niche is for the faith-based community, but we are an inclusive organization. We're faith forward, not faith forced. I am a Christian. Everything that I do, it's just, I can't help it. It's like a tenet of who I am. And we are, everything that we are comes through in what we do. Yet and still, we accept people of all walks of life, and the helpful will, I have to read that question again. And the help will still be helpful to you. I'm going to scroll. Let me click on this question. Do you usually? All right. And you'll find on this slide our website and our phone number. Right now, we're licensed to care for patients in the state of Michigan. And we have plans to expand across the United States and hopefully globally as well to meet the call to this global health crisis. If you are not aware, we are in a global health crisis. We were even before the pandemic, but especially now. And so there's a huge gap between the services that are needed and the services that are provided. So this is our answer to that crisis, is to provide loving, caring, compassionate mental health services. All right, we'll go to the next slide. What is this? Is there questions? Are we done? All right. Good, this is the time for questions. I hope that wasn't too much all at once. I battled with, okay, how deep do I go? Hopefully that was digestible for you all.
That was great. You provided some very, very, very good information. Definitely appreciate it. So everyone, please feel free to come off mute if you have questions, or if you want to share your point of view or some things that you've done. And while I'm waiting for questions to come in the chat, I do want to, and I do see one question, Crystal. I do want to thank the board, advisory board of directors that are here, Meredith Hurston, Jasmine Hall, Shanita Colbert, as well as Kiata Sumter or Nikki Sumter, Lanice Hutchins, and Misha Thomas. And I believe, I hope I'm not missing anyone. I apologize in advance. But the one question is, do you usually have your patients trial lifestyle modifications first before starting medical management?
The answer to that is it depends. It depends on the severity of symptoms that the patient is having. I'll give a couple of scenarios. If a patient is having hot flashes, they're tolerable. You can open the window, turn the air on at night, put a fan on yourself. But every other symptom is manageable, not severe. You're not having those out of whack periods that are alarming, those things that should send you to the doctor's office like we discussed. For those patients, absolutely, we'll try lifestyle management. But the goal is always as little medication or as little, for as little as possible. So we want the lowest amount of medication for the shortest amount of time, for the highest amount of effectiveness, if that makes sense. So you don't want to jump into a high dose of medication when you can kind of wade in the water first. And so I would answer that by saying it depends. If a patient comes with severe symptoms, their periods are, their periods are, they're having clots, they're having hot flashes, the symptoms are intolerable, then we can definitely discuss medication from the onset. Depends on the patient.
Thank you. Thank you for sharing that. Any other questions? And Crystal, I do want to, actually, let me go to Crystal Sanford Brown. Hello, everyone. I had 5 surgeries in 18 months, resulting in an immediate onset of menopause. I can recall sitting in an exam room at Carmanos at my oncologist, asked if I was depressed after my 3rd unsuccessful surgery to see some massive loss of blood through long menstrual cycles. I responded, yes. Within 5 minutes, someone arrived in a white jacket to usher me to the psych ward. That's not what I needed. I needed the bleeding to cease, like the woman in the Bible, referencing the woman with the issue of blood.
Wow. First of all, I'm sorry that happened to you. That's not supposed to go like that. I am so sorry. Like, can we use your story as a case study? Do you mind, Ms. Crystal?
Absolutely.
Okay.
I am, thank you. Thank you for this. And thank you, Dr. Joy, for reaching out. Um, I sincerely appreciate the communication. I had no idea that gynecological issues were both on my maternal and my paternal side because no one talked about it. So when I started developing these symptoms at 16, I wasn't sexually active and I didn't have a menstrual cycle for a year. And, nobody talked about it. So I was immediately put on progesterone and Provera at 16. And so I didn't think I was going to have biological children. I have 3 spoiled adult children now that have no idea, the result of my body of having them. However, I'm so grateful for these conversations, and I just wish we had. No, everybody should be here to hear this because we need to get this information out. So yes, please feel free, whatever you could do. I'm very transparent in and Dr. Joy and I have spoken about this as a result in trauma, because even now, I have a vaginal uh, therapist. I'm not really comfortable with her because of so many incidents that I've experienced, but she is working with increasing my vaginal wall strength. I try to do Kegels when I remember them, but who has time? Um, but yeah, I resonate with a lot of the information you shared. I am 21 years cancer free from ovarian cancer, which I know a lot don't survive. So I am so grateful. So whatever information I can share, I am open to it.
Thank God for your life, Miss Kristen. Thank
Thank
God for your life. You are a blessing and an example, and may God give you many, don't get me started. May God give you many more years of life and health, and may you be a light in dark places. You walk through it
you.
so that other people don't have to.
Yes, thank you. I appreciate that.
I do want to speak to something that you mentioned about the relationship, the historic relationship between Black and Brown people and mental health professionals. Can we go there for about a minute and a half? Okay, thanks.
Please do. Yes.
So we know about some of these issues and the tension, the violence, the gruesome practices that have taken place where we were used like lab rats and guinea pigs for medical discoveries. And here is my answer to that. Absolutely wrong, unequivocally evil. We understand that. That's why these sorts of forums are so important, so that you're not going in feeling unarmed. Meaning you sit before someone like me, any medical professional, and you feel like, okay, whatever they tell me to do, I'm going to do it. That day is done. And I am a medical professional. If you have a doctor who has a problem with you having challenging information, has a problem with you asking questions, has a problem with you saying, look, I looked up on Dr. Google and this is what it said. Do you agree? That is the wrong medical provider. Keep looking. I can personally attest that there are providers out there who are willing to be wrong, who will agree enough to say, hey, this is what I was taught, but let's explore some new thoughts together. Let's see if what you're talking about is something that's feasible. Can we do some watchful waiting? We're going to tie this into menopause. Do I have to just throw some estrogen at you on a pill? Can we monitor you once a quarter? Can we see how you're moving along? Can we see what's medically necessary? That's a terminology we need to get used to saying, because I can tell you now that I've had both sides of the spectrum. I'm on the inside, y'all. There is money to be made when I pass out a pill. I would recommend you ask your medical professional about their treatment approach. How do you feel about medications in general? What do you think about the holistic medications? What do you think about lifestyle changes? Have that conversation because you want someone, your medical profession, to align. You don't want to constantly be at bat. Because the risk is that, I'm going to just tell y'all, the risk is that you get labeled as non-compliant, difficult, one of those patients. That may be the overarching thought, but there are people out there who will realize and recognize, hey, I was taught according to a system, but everybody in the world doesn't fit in that system. There are anomalies, and we're not just going to herd people through the system like everybody's the same. I hope that's helpful. So get information, and all that getting, somebody get an understanding. Learn as much as you can. Reach out to Dr. Joy, who is a resource all by herself. And if she doesn't know, she will share her network with you. Many other organizations where you can search websites, articles. There's Google Scholar where you can read through articles and information. A lot of it is easy to read through. It's not always technical jargon. And so I would encourage you to arm yourself with information, and that when we know more, we feel less afraid and intimidated. So we can sit before a doctor who's telling you, you're going to do this and you're going to die. And you're going to say, I'm fine. Thank you. Thank you for your time. And you can walk out and feel empowered. Don't let people scare you to death. The other thing I would ask is that you mentioned, Ms. Crystal, that sometimes we don't talk about these things. Ask Mama Nim, Grandmama Nim. Next time, I know that some families are more preserved with health information. They almost see it like it's personal. It's something that shouldn't be shared. But wait for those moments. See if you can seek out those times. Ease up to grandma and to mama while she's baking her pound cake. You're like, can I ask you something? Why? It's not just for to be nosy, but make sure you approach it in, hey, this is something that's been going on generationally. Can you tell me about your menopausal phase? What was it like for you? What happened with them is likely to happen with you. It's not in all cases, but it's very likely. So you at least want to know, again, knowledge is power. You at least want to know, okay, how did grandma transition through her menopausal phase? Did moms look similar to that? Because if that's the case, if you can see a trend, then you can know and prepare for how your menopausal phase will take place as well. Is that helpful?
Absolutely, Dr. Crystal. My mom was raised by her grandmother her grandmother was like in her late 70s, and my mom was 6 of the oldest of 4 children. So her father was a papa with a Rolling Stone, so he came home whenever. So she was more like the adult who did things out of the home. So I even earlier today, I asked my mom, who's very open with me, and she attends sessions with me when I speak, because I do speak on ACEs, adverse childhood experiences, and on domestic abuse, child molestation. These are all a part of my story. And she goes with me, and she's very supportive. I always say, I don't blame my parents. They did the best they could, the best they knew. However, I asked my mom, I said, did your grandmother ever talk to you about sexual experience? Because at the onset of my menstrual cycle, I got one of my mother's old belts. I'm almost 60, so we didn't even have adhesive pads. I got an old belt. I got one of those heavy brick pads, and it was nothing said. It wasn't anything celebratory, or it wasn't, I read, Are You There, God? It's Me, Margaret. So it was different with my one daughter. And as I am an advocate for other children, so I just wanted to know, like, why didn't you speak to us about certain things? And again, it's because she didn't have that. Yeah. So it does. A lot of what you stated, almost everything you stated resonates personally with me. And it's how do I take that information, move it forward to be more knowledgeable in the advocacy work that I do? Because I don't want anyone to experience what I experienced. I mean, not even knowing. And I've had 15 surgeries. This carpal tunnel was my most recent in June. Before it was a week old, I was back at the hospital in emergency with blood and mucus coming out. And the three resident neurologists, female white women, told me after they got my temperature down from 102 and the white blood count cell, they got that stabilized. And then the next morning when they did the rounds, they told me to go home, take a picture, upload it on my chart. They would give me Keflex. You're going to be okay. I said, oh, I'm not going home. No.
And Crystal, I want to say that I think like what you're doing in terms of sharing it and in terms of being transparent and sharing your story, that alone is helping so many people. And that's the thing, is that so many times we don't share because whether we're ashamed or we are private. And anyone who knows me, that I am a private person when it comes to a lot of things. But this is an area where God is opening me up in as it pertains to sharing my story so that people know it's okay. It's okay to go to therapy. I see Trish mentioning here, I have an appointment with my therapist tomorrow. And for us to start talking about therapy, and it becomes more common and it becomes a norm and not a taboo. A lot of us, and like Crystal Harris ended up mentioning, she said, while it's faith-based, we're not forcing, the faith on anyone. And so a lot of us, though, especially if you grew up in a church, it was always, we don't go to therapy, we just pray. But some things, you is faith without works, right? So I can have faith, but I still got to put in the work and seek out the professional help as well. So I always say going to therapy, sharing your story as the Holy Spirit leads in terms of sharing your story and who you share it with. But I do believe that that is helping so many people. And Crystal also mentioned advocacy. We have to, and that's where advocating for my uterus comes from, because I was told to have a hysterectomy and I did not need a hysterectomy for my fibroids. And I still have my uterus because by the grace of God, God gave me the wisdom and my background in research to do what Crystal mentioned. Let's research. Let's go to Google Scholar. Let's go to PubMed and all of those sites, but also the resources to tap into other physicians and go to seek a second opinion and third opinion. That's the other thing as well. I do want to share something. Meredith mentioned something in here. One of our board members, she said, Crystal, she said, this was really helpful. I've been going through the perimenopausal period. It's a little earlier than I expected. It hasn't been bad enough to seek medical attention, but I didn't know what was happening to me at first. And so, again, just knowing that we need to share this information. We need to make sure that it's becoming more of a norm, us talking about polycystic ovarian syndrome, talking about endometriosis, talking about fertility, and even the egg preservation phase and egg freeze, and having conversations about menopause as well. All of these things are needed. And us, again, sharing our story. Crystal, keep sharing your story. And Charmaine said to you specifically, she says, and I'm trying to find, I'm sorry, she said, Queen Crystal Sanford Brown, thank you for sharing your heart. And so that's the thing. You are impacting others. Crystal Harris, you are impacting others by sharing your passion that resonates as it pertains to therapy. So for anyone that's listening, whether here today, whether on Facebook, or in the future, if you're listening to the recording, if you have been going back and forth, wavering between, do I go to therapy? Do I not go to therapy? I don't want people to think I'm crazy, and all of that, go to therapy.
Yeah.
I'm telling you, go to that, because even if it is not, so for instance, I have a therapist. There is nothing going on in my life. I'm not depressed. I don't have anxiety. I don't have, so it's nothing a matter of like any type of diagnosis or any traumatic event that I'm dealing with, but I go because it is necessary. Just like I go to my annual appointment for my annual physical or my annual with the gynecologist, my mind, my mental state and my emotional state is just as important. So I am an advocate for mental health. And Crystal Harris, I'm gonna turn it back over to you for any last words that you may have about menopause or mental health as a whole.
You was preaching real good. Listen, I'm about to pass the plate now. Hold on. I'll just echo what you said about the importance of mental health. I recommend bare minimum an annual mental health checkup, like you do your physical exam, preferably a monthly mental health checkup with a therapist would be ideal. Why do I say that? Because life happens. Life does not stop happening. And I think that just because we don't hurt doesn't mean we don't need healing. Did you hear what I said? You don't have to have tears. You don't have to have a mental breakdown. You don't have to have any of those things happening. Picture this with me. Life is coming at us. Kids, business, family issue. Good God from Zion. All of those things are happening. And we've got to place these things in our life. It's our processing system. And sometimes things can get clogged in that processing system. And because our hearts have hiding places, your heart and my heart has hiding places. Sometimes we store things away. We'll say, I'll get back to that later. Not a big deal. And then we get in a relationship with somebody, a professional relationship, a personal relationship, and whoop, there it is. There's the stuff that we packed away that we never processed. Monthly check-ins with a medical professional, mental health professional can help make sure you don't have clutter in your heart. Heart clutter is the reason for anxiety. Heart clutter is a reason behind depression, not the reason, but a reason. Heart clutter helps really as a contributor, a key contributor to mental health disorder. People don't know how to process their pain. One of the questions I will ask every patient, what do you do when you're in pain? Everybody do something. Some people Amazon, some people eat a tub of ice cream, some people pray, some people get involved in church, some people dive into work. Everybody do something. Is that something healthy, or is that something contributing further to your heart clutter? And so this is something that I would leave as a final word for all of us. Oh, well, okay, let me just be honest. Anybody got a good water-based lubricant? I've never used one.
My insurance company sends me like an off-brand, but I'm being honest. How often do I have sex? But I want to make sure that if I use it, I'm using the right one. It's like an off-brand. I could go get it, but no.
As long as it says water-based, it really
Okay.
doesn't matter the brand. That would be my recommendation, as long as it says water-based.
Okay.
Thank you again, Joy, for having me today.
Thank you. Again, I so appreciate you, and thank you to each and every one of you that came today. Please stay in touch with us. You can stay in touch and learn more about advocating for my uterus by going to advocatingformyuterus.com. You can also follow Advocating for My Uterus on Instagram as well. And then please stay in touch with Sound Mind Health Services at soundmindhealthservices.com. I want to say, Crystal, can you just verify your license in the state of Michigan, right? So you can you share that piece?
Yes, I'm licensed in the state of Michigan. As we expand, I'll be happy to share that. Our plan is to expand in the Midwest first, and then for states, into states that are full practice for nurse practitioners, meaning we don't need medical oversight. But right now, it's just the state of Michigan. So if you're in Michigan, come on. I'd love to see you.
Thank you so much. So again, soundmindhealthservices.com. And Crystal, if you can put that in the chat as well. And then I want to just ask you all to be on the lookout for what's next. We try to do these, again, the board and I, we try to do these based off of the health month. So again, October is Menopause Awareness Month. I want to say October 18th was World Menopause Day. Last month, we had Polycystic Ovarian Syndrome Month with Dr. Omari Young. We've had Dr. Erica Marsh from University of Michigan, Ann Arbor to talk about uterine fibroids. And so we're going to keep having these discussions. There is, for everyone who registered, please check your junk mail as well. There is going to be a follow-up email with the link to the YouTube video. Please feel free to share that with others, because again, we want to get information out there to everyone, and we want to advocate for our uterus. This is not something that's specific to one race, but we do want to make sure that we are getting the information out to all women. But the issues that we tend to see, the disparity is with Black and brown women. So please share that information. Have an amazing, amazing, amazing day, everyone. And again, thank you so much, Crystal Harris, and thank you all for being here. Have an amazing day. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks.